All right, good morning, everybody. I'm not used to speaking in a microphone, so it might come out kind of weird. My name is Christie Clement. I am the chief of the Communicable Disease Unit at the Oakland County Health Division. I have been guest lecturing for community health nursing classes on epidemiology and public health basics for about 10 years. I guest lecture at Wayne State, and then this is, I think, my second year coming to OU. So just a little bit about my background. I am a nurse by training. I am a graduate of Wayne State's accelerated second degree program in 1999. And so I think, are you on your last semester? Yes. Okay, so I'm here to tell you that you will survive, you will get through it, you're almost done, you're in the home stretch. I remember that last semester very well. So I graduated with my bachelor's from Wayne State in 99. I did work in the hospital for a year. I did the med-surg thing for a little over a year. But really wanted to go into public health, and so I ended up transitioning to Oakland County in 2001 as a public health nurse, where I worked there for many years. I went back to Wayne State, got my master's degree in public health nursing, and graduate certification in public health practice in 2011. And I worked all over the county in maternal child health and HIV, STD, immunizations, children's special health care services, lead services, school health, you name it. And then I took a break from the county and went over to Wayne State for a few years and worked for their student health services for a couple of years, and then came right back to the county where they plopped me in communicable disease, and that was back in 2015, where I was a nursing supervisor and kind of worked my way up to the chief of the unit, where I now oversee our public health nurses, epidemiologists, in the Communicable Disease Unit, where we investigate reportable diseases, and I'll talk a lot about that today. Under my umbrella, we also have HIV and partner services, and we have a PrEP clinic where we do pre-exposure prophylaxis medication for people who might be at risk of HIV infection, hepatitis C treatment, and then we also have a harm reduction clinic where we do syringe services and harm reduction type of services for people who use drugs. So that's me in a nutshell. And so I am going to talk to you today about just public health basics. There's a lot of slides, and so some of them I'm going to just kind of gloss over so we can get to the more interesting stuff and spend more time on that. But feel free to raise your hand and interrupt me at any time. Some of it, admittedly, can get a little dry, especially when we get into like the biostatistics part. But don't worry, you're not going to have to like be calculating any, biostatistics. It's just kind of to give you an overview and an idea, of what you're reading when you're reading articles and seeing different statistics quoted. So I'm going to go ahead and start sharing. All right, I just want to put this in. Oh, there it is. Okay, it's at the bottom. Okay. Is there a way that it'll let me see my notes as well? Okay, it's not a big deal. So by show of hands, how many people here are planning on going into public health? Okay, I got an eventually. Okay, so this is pretty like what I usually get. So I usually get 0 to 1 people who raise their hand and say, yes, I'm planning on a career in public health. Because most people, when they go into nursing, it's not like the first thing that you want to do. For some people it is. And that's okay. Like one of the things I love most about nursing, and I've been in this career of 20 plus years, is that there are so many different options. And if you do one thing and it's not for you and you don't like it, you can find a whole different field within nursing to do. And so that's the best thing. And so maybe someday you'll end up in public health, but maybe you won't, and that's okay too. I won't judge you for it, because we still need our nurses in the emergency rooms and the med surg and in the primary care and all of that stuff. But having a good basic knowledge of public health and just a basic grasp on it will make you overall a better nurse. So that's why it's important to just have some basics on the public health side of things. So I'm going to talk to you about epidemiology. What is epidemiology? It's the study of illness in humans. So it's looking at how diseases or health states are distributed among groups of humans, among people, among populations and communities, and the reasons why certain populations might have different diseases or health states as opposed to others. So basically, we're just looking at factors that influence health and disease in populations. In epidemiology, we like to think of ourselves as disease detectives. So we're always trying to find out who's got diseases, why they have them, where they got them from, really for the purpose of stopping the spread of disease and increasing lifespan and decreasing morbidity and mortality. So what's different about public health and epidemiology is it really goes beyond what you've been learning mostly in nursing school, and what you'll practice is just that one-to-one patient-clinician mode. It goes beyond that. So it's beyond considering just the patient that you have in your exam room or your hospital room. It's going beyond that and considering more than just what's happening with that individual at that moment to everything that may have brought them to that space and where they're going to go when they leave and how that's going to affect their health. Okay, so when we're looking at the distribution and the determinants, health determinants is something that you might be already familiar with, but we'll talk about it quite a bit today. So what we're looking at is basically just the who, when, where, why, and how. And I didn't put the what in there, but the what as well. Of who is getting diseases, who has certain health states or non-health states, when are they getting them? Are we looking at a time in the century? Are we looking at a time in the year? A time in the day? Where are they when they're getting them? Like looking at countries, looking at zip codes, looking at neighborhoods, looking at buildings, you name it. Why are they getting them? Do they have multiple, comorbidities? Are they getting them because of genetic factors, environmental factors, different exposures? And then how are they getting these diseases? So what's the route that they're getting them? Is it in the air? Is it in the food? Is it from other humans? So these are what we're looking at when we look at distribution and determinants of health and disease. Oh, okay, and there's some fancy animation that I did because I'm very fancy. I have a child majoring in animation, and I think that he would be embarrassed by this. Okay, so a few terms that we've heard a lot about. You've become very familiar with the term pandemic in the past few years. So just to break it down, the difference between epidemics, pandemics, endemics, and all of the emics. So an epidemic is basically when there's an outbreak. Let me just start back a little bit smaller. We start at the smallest group of disease occurrence we would call just like you have a case, and that's one person. So someone has tuberculosis, that's a case of tuberculosis. Someone has COVID, that's a case of COVID. A cluster is like a small group of people that have a disease. So we might have like a cluster of, influenza in this classroom, but it hasn't gone throughout the whole school, it's just a little cluster. So we'll see maybe a few cases. An outbreak is when it's just like spread quite a bit throughout that particular community or population. So like we'll have like norovirus outbreaks in long-term care facilities where a lot of people in the whole facility have norovirus. We see those in schools too. We see hand, foot, and mouth is an infection. We see in all the preschools and daycares right now, they'll have outbreaks. And then when we go beyond outbreaks, we go to epidemics. And that's when an outbreak has just spread further among a population. And it's where it's at a higher level, rates are higher than we're used to seeing them. So for example, influenza, we have like kind of a baseline of influenza that's just expected because it's endemic, and I'll get to that. It's just part of what the diseases that we have in our world are. So we always expect in Michigan, it's somewhere around 2% of doctor and hospital visits are due to influenza. Well, it becomes an epidemic when it rises above that normal level, when we're seeing way more than we would normally expect to see. And again, it's not as big as a pandemic, but it is in usually a geographic area. So our epidemic, you might have a disease that becomes an epidemic in like maybe Texas if you've got an outbreak of, we haven't seen this, but they could get like a plague or something down there because they still carry it down there. But it's much more geographically limited. And then once it gets to a pandemic, then we've got it worldwide, right? So COVID started as an outbreak. It started as a case, guy with pneumonia in a hospital in Wuhan, at least to our knowledge, right? In Wuhan, and then there were more cases, so they had a cluster of a few of them. And I was just reminiscing back 4 years ago, we just started around this time, I think it was December, started going to meetings. There's this pneumonia happening over in China. What is that? There were a few cases, and then as it spread, it became, an outbreak over there, and then an epidemic, and then eventually it spread throughout the world, obviously, and then it became a pandemic. So it's basically just an epidemic gone wild, right? So it's just across the world, or a very, very wide area affecting a really large group of people, and it grows exponentially, so it grows fairly quickly. Before COVID-19, if you remember if any of you remember in 2009, time flies, I can't believe that was 15 years ago, we had the H1N1 flu came out. That was considered a pandemic also because it was a novel form of flu that we hadn't seen in many, many years. And it started small in Mexico and it spread very quickly, and we didn't have a vaccine for it. So that was a pandemic as well. So strangely, I've done 2 pandemics in my career in public health. Luckily, because we already have, we knew the flu. We didn't know COVID, so we knew kind of the natural history of the disease, and I'll go over the importance of knowing the natural history of diseases, that we kind of knew what to expect. It threw a few things in that were different. It was affecting younger population, but again, it wasn't, terribly different from a lot of other influenza, and they had the basis for a vaccine, so they could get a vaccine out really quickly. A couple differences between that pandemic and this one. Endemic is where it's just a disease that we see normally in a region that we expect to see. So, flu's endemic here. Things like Lyme disease are endemic here. West Nile virus in the summer, that is becoming more endemic. Things that aren't endemic that are like concerns are like measles is not endemic anymore, but we'll have a case of measles every so often. We did have a outbreak a couple of years ago. But while it's not eradicated, we consider it eliminated because it doesn't, we don't have cases proliferating in the US, and it's not endemic. It's endemic in other countries, right? Malaria is endemic in certain countries where you expect to see a certain amount of cases of malaria. It's not endemic here. We don't see malaria generally unless it's imported. Any questions about those? So this is just kind of a visual representation of our normal expectancy, name any disease where the dotted line is, excuse me, is where you would kind of expect to see, and these are hypothetical numbers. You'd expect to see 6 cases per year. And you can see as it rises above, that's when we're having outbreaks or epidemics. It rises above the normal level that we're used to. And we'll get there. We're kind of there with COVID. Like we're seeing spikes, and we see little spikes and outbreaks, but it will get to the level of flu where we're just used to seeing a certain amount of COVID year round, and then epidemics and spikes during different parts of the year. And this is, excuse me. This is a graph that's reported annually, or reported actually weekly, so we can see where we are with influenza. And this is one of the ways that we track influenza in Michigan, in the country, actually. So in Michigan, our baseline is about 2.5% of doctor visits are related to flu-like illness. And you can see as each week goes by where it increases above that baseline, and that's when we're in like epidemic status. This is back February last year we were low. It's interesting. I don't think I put one. It's interesting to look at these layered for different years. I'll do different colors for each line across it to see like where the flu peaks are every year. It's really interesting to see. Sometimes it'll peak in like December, and then other years it won't peak till March. So it's pretty interesting to see how that happens. All right. Who are these guys? Raise your hand if you think it's A, John Grant. No. B, William Farr. C, John Snow. Couple John Snows. D, Florence Nightingale. I do not watch Game of Thrones. However, I think one of the first time I gave this lecture, I was talking about Jon Snow, and people are like, Game of Thrones, and I never watched it. And so now I throw that in. And I don't even know if it's still relevant. Do people still watch Game of Thrones? Okay, so this probably is the last year I'll have this guy. You're going to think of something different. Anyway, Jon Snow, one of the best known epidemiologists, sometimes referred to as the father of epidemiology, shares the same name as the Jon Snow from the Game of Thrones. I think that his contributions to the world, the real world, were far more significant. And we'll go over one of his most important activities in a minute here. The others on that list are also important epidemiological figures. John Grant started patterns of disease in populations. He started looking at demographics, basically. And so, like, what is the address of the people who had a certain disease? Like, what are they? He's looking at commonalities in terms of demographics. So address, race, gender, that kind of thing. And then William Farr, he was kind of started this statistical collection. So looking at the numbers and causes of deaths with statistics, and looked at vital statistics, worked a lot with like death records and birth records. He worked closely with John Farr. And then our girl, Florence Nightingale, our hero nurse, she was also really influential in early epidemiology. It wasn't recognized then, but looking at descriptive health statistics to prevent needless illness and death, and that goes into like infection control and things like that. So she was really looking at, during the war, like who was getting infections and dying and why. So gathering that data to create interventions to decrease morbidity and mortality amongst the soldiers. So that was like some early epidemiology that she used as a nurse, who I'm sure didn't consider herself a public health nurse. She was, just on the front lines of the Crimean War. Okay, so John Snow, back to John Snow. Is anyone familiar with the Broad Street pump? Okay, so the cholera outbreak was really influential. His investigation it resulted in improved sanitation and really the introduction of disease and mapping. So I'm going to go over this in a little bit of detail right now. So in London, there was a cholera epidemic. And it was John Snow that decided to map out the cholera cases. And so if anyone's familiar with geographical information systems, or GIS, it's where you map things visually. This is kind of like a very early geographical information systems map. Essentially, every dot on this map represents a case of cholera. So they're having this cholera, and he had some theories as to why there's a cholera outbreak. It's a disease that's waterborne. He had some theories, but rather, just floating these theories, like, I think it might be related to the water pump, and people didn't believe him. So he said, okay, I'm going to map this out and look where these cases are, so I can actually see where they're clustered, and then kind of compare that to where people are getting their water from, to see if it's the people who are getting this particular water from the Broad Street pump, or another pump. And incidentally, of course, this is before indoor plumbing, where people went down the street to the neighborhood pump to get their water for cleaning and cooking and whatnot, and bring it back home. So what he found is that the death rate from cholera and the cholera case rates near this particular pump far exceeded the death rate and case rates in other areas of London. Okay, and I normally don't like to read slides, but I like to read this one because it's really, it really tells like how important it is. It really describes how he used that information to determine that the Broad Street pump was the cause of the cholera outbreak. He said, I found that nearly all the deaths had taken place within a short distance of the pump, this Broad Street pump. There were only 10 deaths in houses situated decidedly nearer to another street pump. In 5 of those cases, the families of the deceased persons informed me that they actually always sent to the pump in Broad Street because they preferred the water there to the pumps that were nearer. And in 3 of those other cases, the deceased were actually children who went to school near the Broad Street pump. So in his investigation and asking questions, he found out that the deceased who didn't live near Broad Street were actually using that pump. That's part of what we do in communicable diseases. We investigate and ask all of these questions. So with regard to the deaths occurring in the locality belonging to the pump, there were 61 instances in which I was informed that the deceased persons used to drink the pump water from Broad Street, either constantly or occasionally. And the result of the inquiry then is that there has been no particular outbreak or prevalence of cholera in this part of London, except among the people who were in the habit of drinking the above mentioned pump. So the Broad Street pump. So what did they do? Shut off the Broad Street pump. Everyone had to use a different pump. The cholera outbreak resolved. I'm sure it was a little more complicated than that. But that's essentially what he did. And so that he was very instrumental in mapping the diseases, doing the investigation, asking the questions, and not making assumptions. This person lived over here, not near that pump, and didn't make the assumption. Did the investigation, ask the questions. And that's what we did. And incidentally, it's our nurses in the health department, our public health nurses, who do our disease investigations, who ask those questions and do those investigations. They are like our front lines of disease investigation. Okay, this stuff I'm going to go through a little bit faster because it's kind of boring, but it's good to kind of have the basics. And this just goes through a few of the epidemiologic model, just kind of frameworks for considering disease and disease transmission. And they go from like really basic, old school to a little too much more in depth. So this is kind of just your classic, very basic epi triangle. So it just looks at three different things: host, environment, agent. So the agent is if we're looking at communicable disease, the agent is the infecting organism. So it could be a virus, a bacteria, a fungus. The host is the person who can get the disease, and then the environment is everything internal or external to that host. So whether it's their own immune system or it's the weather that they're in. So those all affect each other. So it just kind of keeps it very basic. And this is just gives you some examples. So an agent could also be biological. It could also be chemical. It could be nutritive. It could be something physical, like a building collapse or an earthquake, or an environmental factor, psychological effect. And then the host is the person or animal who's susceptible, who could actually get the infection or the health condition. And again, environment, anything that can make someone more or less vulnerable to a disease. So again, like health status, comorbidities, immune status, genetics. I could go on for a long time on that. Okay, so this gets a little bit more complex. It takes the epi triangle a little bit further, and it says, well, there's not just those three things, but there are all these other things that can come in to affect disease status or whether or not someone gets a disease. So there's social environment, their physical environment, their biological environment. So it takes environment a little bit more in depth. And then the web of causation just takes it further, and just basically it's looking at saying that it's not just one thing that causes disease. There are a lot of different factors that cause it beyond just the agent or the environment. There are a lot of other factors, and that's pretty much all you need to know about that. We've got all of these things. This is obesity among adults with developmental disabilities. I think I took this example from your book. So there are a million things. It's not just like too many calories in, right? There's loneliness, stress, lack of resources, lifestyle, et cetera, et cetera. And then, I don't know why I did natural history. I'm going to go back to that one in a second. And then we go even further, and then we go to the ecological model, which is basically starts with the intrapersonal. So that's like within the actual person, within yourself. It's that person. And you think about your patients that you're taking care of, whether they're there for like asthma or diabetes or surgery, or they had a car accident, or who knows, whatever. What's their knowledge about their health and their health status and their disease and their health condition? What are their attitudes about their health? How do they feel about about being healthy? Is it important to them? What kind of behaviors do they themselves have that contribute to their health status, self-concept? We look at skill. So you can, go back to some like nursing theory that I'm going to pull out of the very back of my brain. I think it was Orman who looked at self-agency or something like that. So what kind of skill do they have? Think about, people on diabetic care, what's their skill in terms of their ability to monitor their blood sugar, if they have to do injections, things like that, and developmental history. So it's basically everything that is just only within that person's control. And then we go one step out and we look at interpersonal processes and primary groups. So who's right around that person that might be affecting their health. So think about a patient, just do it in your head. You don't have to, we'll do it out loud later if we have time, that you may have taken care of in a clinical. Just think about that patient and what their diagnosis or what you're taking care of them for. What might be in their informal or formal social networks that affects their health, their family, the health practices of the family. What kind of foods are they cooking? What kind of house do they live in? What kind of activities do they do? What's their social circle like? Are they hanging out, with people who drink alcohol, people who exercise, people who game, whatever they do, and think about how that might affect them. Work group, friendship networks, anything that might affect, have an influence on their health status. Let me go a little bit out to institutional factors. And so these are social institutions, organizational characteristics. These can be formal or informal. So think about, just for example, like at OU, and this is just a very basic example, there's rules about they have things in the vending machines. They have healthy foods, not healthy foods available to you. They have like restroom facilities available. Think about people who might be working someplace where they don't have that available. They're working, they're migrants working in farms or something like that. So what's available within the institution to contribute to that health of the person? Community factors is like kind of, you can go into some institutional factors looking at community factors, but it's more community looks at like, what are the relationships among the institutions within a community? Like how much do they work together? So for example, at the health department, our partnerships are super, super important to us. They have been instrumental in us dealing with outbreaks, measles outbreaks, Mpox outbreaks, COVID, everything. So we work pretty cohesively with partners, and that allows us to address health concerns of communities because the partners work together. But if we all work in our separate silos, it makes it a lot harder to work together and make a community healthier. So think about a community, whether or not the community institutions are working together. Think about like local government and if they're able to work together with the businesses and to make the community safer. And then piggybacking onto that, government public policy. So any official actual policy, law, or rule that affects health. So whether it's think about people with disabilities, so doors that open automatically, sidewalks that are safe for wheelchairs. Think about taxes on cigarettes, on sugar taxes, seatbelt laws, whether or not there's a helmet law. So any kind of law that might affect someone's health. So that just takes it further from just like agent, host, environment to all these other factors that affect our health. And so just keeping that in mind and just always keeping these factors in mind when you're taking care of your patients, well, I think it will really make you overall a better nurse. Okay, so I'm going to go back to the natural history of disease. I put this slide in like a really weird spot. I don't know why, but I mentioned it earlier. So natural history disease is basically just what is the progression of a disease if we don't do any medical interventions. It's really important to know the natural history of a disease because that's how we know when to put interventions in place to stop the progression of disease or stop the transmission of disease. So for example, when we know the natural history of disease, we know when somebody becomes infected, how long they might be asymptomatic before symptoms start, how long before they become contagious, if they're going to be contagious, how long are they contagious for, at what point can we put an intervention in and try to stop the continuation of the disease or stop the transmission. So for example, we know the natural history of measles. We had a measles outbreak in 2019. We hadn't had one in a long time. It's very stressful. It's a vaccine preventable disease. We hadn't seen it in a long time, but we know measles because we know the natural history of that disease. So we knew what interventions to put in place. We know that measles has an incubation period of up to 14 days. So we know if someone was exposed, it's up to 2 weeks that they might develop the infection, right? We know that someone is contagious with measles for 4 days before they get a rash through 4 days after they get a rash. So we knew this is when this person was contagious based on their rash. This is where they were. We need to alert other people who might have been around them during that contagious time that they could have been exposed. We knew that if you give someone a vaccine within, I can't remember, pulling this out, maybe 72 hours of exposure, maybe 5 days, don't hold me on that. If you give them a vaccine, you can greatly reduce their chance of developing the infection after exposure. We know that they're no longer contagious after 4 days after their rash started so that they're able to be released from isolation and go back to work and do things. So that's just one example of the importance of understanding the natural history of disease. Now, COVID, we didn't know the natural history of the disease. Nobody knew what to do. This is a novel infection. We didn't know if you were, at the very beginning, are people contagious pre-symptomatically, asymptomatically? How long are they contagious for? What if we give them a vaccine? How long do they need to quarantine, isolate? And that's stuff that we're learning with time. And that's a little bit of a less straightforward disease, but that's just what we mean by natural history of disease and why it's important to know. Okay, so I'm going to kind of glide through these slides, just things that we're looking at when we're applying epidemiology in practice. You do individual assessments. You guys do that when you take care of your patients, so you can apply these epi principles considering interpersonal interpersonal, institutional factors. Apply all of these to your patients as you're taking care of them. Like, how did they get here? With this exacerbation of COPD or whatever it is, why did they get here? Where are they leaving after? Where are they going after? And how's that life going to affect them when they leave? What kind of teaching can I do as a nurse to help them not come back here again, or to decrease the chance of having this episode again? We do a community assessment, so we apply these to whole entire communities. Again, I talked about how looking at whether communities are working together on things, how well their government's working together with the businesses, with the Parks and Rec department, with all the different parts, the different providers in the community. How much are they all working together to promote community health? So again, just consider the epi models when you're looking at those things. You can even think about it as you're just driving, to campus. Like, think about the community. Like, apply those principles to the communities that you're driving through to consider how that might affect the people that are working there, living there, or playing there. And so we use these principles to prevent and control outbreaks, and I'm going to go into that in a little bit more detail, and just, again, improving the health of communities. Okay, so outbreak investigations. This is the fun part for me. We laugh anytime something comes up in our unit in communicable disease. We just jump in. We have our daily things we do. We're always doing surveillance. We're always investigating. But something comes up, and I don't want an outbreak, but this is when we jump into action. And we're we live for this. We had yesterday. You'll probably see it on the news. There was a dog. A stray dog that was found and tested positive for rabies. And so that's when we jump into action, because we were where was the dog? Who was around the dog? Who needs rabies shots? All this stuff. We immediately jump in. So you can do this we do this for communicable disease every day. It's done for non-communicable disease. And if I have time, I'll talk a little bit more about that, because there are some programs in place at the state and federal level monitoring things like cancer clusters and things like that. Exposure to toxins as well. So we investigate. So our public health nurses, they get cases reported. I'll show you how that looks. They might get a case of salmonella reported. They are investigating. They're looking at what lab tests were done, what diagnostic tools were used. Then they're interviewing patients in certain instances. When did your symptoms start? What were your symptoms? Where did you eat? Where were you? What were you doing to try to find commonalities with other cases? That's how we identify outbreaks. And then our epidemiologists take all of that data and they analyze and interpret it to come up with hypotheses and interventions as needed. We don't solve every outbreak. It's impossible. If we did, it would be much more exciting. But we put the work in anyway to try to estimate risk for people. All right. Okay, things that we consider. How effective is the agent for outbreaks? Measles, super effective. Very contagious for people who are susceptible, meaning they haven't had measles and they're not vaccinated. If you're in the room with someone with measles, you've got over 90% chance of getting it. So it's really effective. Tuberculosis, not so much. If I had active TB right now, I'd be more concerned about you people in the front row, but not you in the back so much. I do not have TB. I got tested recently, so just what's the route by which they're infected? Is it airborne? We've heard a lot about this during COVID. Is it airborne versus droplet versus whatever? So airborne, droplet, close contact, skin to skin, things like that. Point source. This is okay. Occasionally we can find the point source. So basically, what's your index case? Where did it originate from? Sometimes it's important to know that with our measles outbreak in 2009, we could identify the point source because he had a very straight line of travel coming directly from other places with outbreaks into this community, and we could follow where he went to identify people in contact. It's not always possible to do that. Secondary spread is basically looking at if I got an infection from the point source, the index case, who else did I spread the infection to? We're looking at how much are we seeing secondary spread. So during our Mpox outbreak, I looked at this during COVID. It was easier during Mpox with smaller numbers. We would collect close contacts from the cases and then talk to the close contacts to monitor their health because they've been in close contact. And secondary spread is looking at how many of those would have gotten Mpox and then passed it on to someone else. We have very little secondary spread there. Again, non-communicable disease outbreaks. I'm going to gloss over that. Exposure. Okay, so moving on to surveillance. This is for me, it's more fun, but maybe not for you guys. Okay, so surveillance is basically just the ongoing systematic collection, analysis, interpretation of health-related data, which is truly essential to how we plan and implement and evaluate public health practice. So we are always watching what diseases are happening in populations. I speak specifically to communicable disease because that's where I work, but there's some institutions somewhere that's always watching other diseases to see what's happening, where it's happening, why is it happening, how can we slow it, how can we stop it, etc. So there's two different kinds of surveillance, active and passive surveillance. So passive surveillance is happening all the time. So there's a long list of diseases, over 100, that are by public health code law reportable to the health department. So providers and laboratories who diagnose these diseases are required to report them to the local health department. We have an electronic platform for that. And so schools are required to report, but it's harder for schools because they're basically reporting based on what parents call and tell them. And so not like actual lab tests and stuff. But basically, it's the onus for collecting this is on the healthcare providers. So we're not going out and asking, how many cases of chlamydia did you diagnose this week? How many cases of, salmonella? Like they're just telling us. So we're just kind of passively sitting there and like giving all this information. I'll show you what that looks like. This is what it looks like. Okay, so this is the Michigan Disease Surveillance System. This is our system in Michigan for reporting diseases. So healthcare providers, laboratories use this, hospital system, infection control practitioners use this. There's a lot of automatic reporting that happens directly from laboratories. So as soon as the lab has a positive, name a test, hepatitis, it'll automatically go into this system. In hospitals, it's they have infection control departments in all the hospitals. They report all of their reportable diseases into the system. This comes to us and we basically go through this every day. We don't investigate every single disease. We can't investigate every case of influenza, norovirus. There's some that we can't do, but a lot of them we do. So this is just an example. So we've got an invasive group A strep in here. We've got a chicken pox. We get a lot of rabies. They're not actual rabies cases. It's people who have been exposed to animals, and we're determining if they need rabies post-exposure prophylaxis, rabies shot. We get a ton of it. This is just an example. So we get some chicken pox, Lyme disease, Giardia. So it's basically everything that you got that's enteric. So that's a lot of our food and waterborne. So salmonella, E. coli, Giardia, etc. All your vaccine preventables. So chickenpox, measles, mumps, tetanus, hepatitis, our tick and mosquito borne. So like Lyme, West Nile disease, Eastern equine encephalitis, anything, malaria, dengue, chikungunya. We do get those reported sometimes, but they're always come from like someone went on vacation or something. Trying to think about my other, some hospital acquired infections, some invasive infections and things like that. So our nurses get these and they start with what's the disease and look at the labs, what labs were reported, was the appropriate lab testing done or whatever kind of testing was done, and then look if they gather medical records as needed. Sometimes they call the healthcare provider, they call the lab, they call the patients for certain to gather all the information. Okay, so that's basically what passive surveillance is looking for. And then our epidemiologists are doing all of their statistical analysis and data tracking, and we're looking at trends and letting us know, oh, we've got an increase in respiratory infections in this zip code, and then we can use that information to look at what kind of public health interventions do we need to do, messaging in certain populations. When we saw Mpox pop up, it was a very specific population that was getting most of the Mpox cases, and so we knew let's direct our messaging and interventions to that population. So that's passive. And then active surveillance is when we are actually deploying our public health forces to go out into communities and find cases, see who's got cases. So when we set up COVID vaccine testing sites, that's a form of active surveillance, because not only we were trying to provide that service to the public, we were trying to find where the cases were at the very beginning. In the measles outbreak in 2019, that was in a very small Orthodox Jewish community in Oak Park and Southfield in the south part of the county. We were going into that community, testing people actively, going into their houses, like a few other nursing supervisors at the time, going like in houses, like, are you having any symptoms? Let me test you, and finding cases. Our TB and tuberculosis, we do contact investigations. So if we've got someone who has tuberculosis, we'll determine who their close contacts might be, who might be a risk, and we'll go out and test them to see if they have it. Things like Ebola, last year there was also Marburg. So these are infections that we're seeing elsewhere in the world. We'll monitor travelers who have been to countries where they're having those kind of outbreaks and monitor their symptoms and watching them to see if they're getting the cases, getting the infection, so that we can intervene really early to prevent the spread. And that is a form of active surveillance. Same with our Mpox. I haven't updated this. It's Mpox, known as now not monkeypox anymore. So clearly, need to update this. We would monitor close contacts. Same with measles. So if we had a case, we would gather their contacts and then we would let them know that confidentially you may have been exposed. We're going to keep in contact with you for a couple weeks so that if you develop symptoms, we can intervene right away and try to stop the spread of that. Okay. I'm going to come back to the ecological model activity because there's so many slides. And what time do we have until?
So just after 12.
Oh, okay. Yeah, I'm going to pass this. This activity is safer if there's time because there's just so much information.
Okay.
Okay, just going to kind of like do just really quick, just to give you does anyone, how do you feel about biostatistics? Good? Yeah. Very rarely anyone says good. I still have flashbacks from that class at Wayne State University for my graduate biostat. We'll just kind of go over some basics. And most like if you're reading any literature, if you are, any information, if you're talking about it, seeing it in the media, in the news, it gives you kind of a basic idea of what's being talked about. So rate is just like basically a primary measurement, looking at like the quantity of a disease or a specific state of health in a group of people, and it's over a certain time. So basically, how fast is it spreading? We look at morbidity rates, so that's how many people are experiencing a disease. Mortality, death rate, how many people are dying of a certain condition. Attack rates is how often a certain pathogen is causing infection in a population or a group. So basically, if I expose 100 people to norovirus with all the same exposure, what's the percentage of them that will get the infection? That's the attack rate. So like we investigate lots of foodborne outbreaks, lots of events where there might be an outbreak associated. It gets reported to us, and our epidemiologists try to determine the attack rate. So of this many people that were at this facility, this many people ate this food, and this is the attack rate of how many got norovirus. Always norovirus, almost always for those things. It's super effective. It doesn't talk about secondary attack rates. Secondary attack rates would then be, of that case, how many people in their household did they spread it to after that, or close contacts. Okay, so it just helps us knowing rates. How many diseases are people getting and how fast are they getting them? Just lets us know the frequency of the disease in certain groups and populations. It helps to determine certain risk factors in groups. And we can use biostatistics to determine probability that certain diseases or health conditions might occur in certain groups who might be more at risk, whether it's by zip code, by gender, by race, by certain lifestyle situations, you name it. Okay, so this is how to calculate rates 101. Are you gonna have to do this for your test? I don't know. Probably not. If you do, probably very simple. Basically, you've got your numerator, your number on the top. So that's all the events being measured. So let's say cases of influenza in a dorm. Everyone who's included in the denominator, the number on the bottom, so it's just basic yucky fractions, everyone who might be at risk. So if we're looking at the rate of influenza in the dorm during 2022, we're going to look at how many people had influenza in that dorm and how many people were in that dorm at the time. So if 10 people had the flu and 100 people were in the dorm, you're going to do 10 divided by 100. Rates always look at specific periods of time. So we're looking, at, you can look over, a generation, you could look at a year, you could look at a month. And again, like when you're reading rates, you'll frequently see like per 10,000 or per 100,000. It just makes it much easier to conceptualize a rate when you make it a bigger number. So it'll be a multiple of 10 rather than saying there were like 0.00653. It's easier to say there were if there were 100, there were this many cases, but if they're in 100 people, but if there were 10,000, it would be this many. It makes it easier to kind of conceptualize the rate and how big the number is. So like we had I think we had 20 cases of tuberculosis in Oakland County last year, and that equates to something like 2.1 per 100,000. So it's easier to kind of conceptualize that, especially when comparing with different communities. Okay, so this is just an example of calculating mortality rate. So if we're looking at a Pontiac long-term care facility, they had 1,000 residents there that tested positive for COVID in 2020. We're looking at a mortality rate, 150 of them died. So 150 deaths over 1,000 who had COVID, that's 1.5 per 1,000 or 1.5 per 1,000. And we're looking at a year, 100,000 per year. Crude and adjusted means that you can adjust rate. Adjusting is just a statistical procedure that gets rid of certain differences in populations. So it accounts for differences in like things like age that might affect a mortality rate or health status. And that's just another by the statistical calculation. Okay, incidence versus prevalence. These are interchanged a lot. You'll hear they do mean different things. In my graduate epidemiology class, my professor put our first question on every exam was the difference between incidence and prevalence. And he said, if you get that question wrong, you will fail the test. And I don't know if anyone failed the test. I never failed the test. So that's how important it was to him. So basically, the basic difference is incidence is looking at new cases of a disease or incident cases, and prevalence is looking at existing cases. So consider something, it's much easier to do for chronic illnesses than very short acute illnesses. So if we let's think of diabetes, and we're looking at the incidence of diabetes in October of 2023. How many people were newly diagnosed with diabetes in October of 2023? That's your incidence. Those are all the new cases. That doesn't include all the people that already had diabetes. Those are the prevalent cases. So they were already living with diabetes. So basically, this is a pictorial of this. We have the prevalence pot. So that's everyone who's currently got a disease. Consider maybe HIV. Our incident cases are brand new cases. Those are incident, they're entering into the pot. Our prevalent cases are the ones that already had it. So we look at a certain time period. What's the incidence of a certain, in a certain disease in 2023? That means all the new cases, not the people that are already living with it. Okay. Sensitivity, specificity, again, another thing that I've seen a lot in the mainstream media in the past few years with COVID testing. And sometimes these are used interchangeably. So sensitivity, they are different. Sensitivity means it's the ability of a test to identify correctly people who have the health problem under study. So if we're looking at a COVID test that has a sensitivity of 80%, if we took 100 people who we already knew had COVID, we've already tested them, we confirmed they have COVID, and we're going to try this new test out to see how sensitive it is. We're going to give that test to these 100 COVID positive people, and it correctly identifies 80 of them as having COVID. It picked up 80 of those positives, it missed 20 of them. It's 80% sensitivity, right? So that's how good it was. I think we heard like there were, when we went from PCR testing to like the rapid antigen testing, your rapid antigen was much less sensitive. So it was more likely to miss some of those positives. Now, specificity is just the flip side of that. It's kind of confusing to wrap your brain around, but it's basically identifying people who do not have a disease in a population. So if I have 100 people who I know do not have COVID, I've already validated that they don't have COVID, and I'm going to do this new test and administer it to them. How often is it going to give me a false positive and tell me somebody does have COVID when I know they don't? So if 95% of the time it's right, it gets people who are negative correct, then it's 95% specificity. The way I used to explain this to people, like back in I haven't done HIV testing myself in a really long time, but the way it used to be in a lot of screening tests are like this. A screening test is meant to be super sensitive. So it's looking for anything that looks remotely like the agent that you're looking for, right? So it's really sensitive. It's going to pick up anything that might look like that particular, like the VDRL for syphilis is super sensitive. Anything that looks like it might be, the syphilis, it's going to pick it up. It's so sensitive. Then you do the confirmatory test. It's much more specific. So it's going to tell me if that actually is the thing I'm looking for. It's not quite as sensitive. It's not looking at anything that looks like it. It's looking much more specifically to see if it's the actual agent that I'm looking for. So it's basically just how good is a lab test at determining whether it can find a false positive or a false negative. All right, questions about that? I know I talk really fast. Okay, a couple different types of descriptive studies. There's analytic studies, descriptive studies. Descriptive studies is just where we're kind of looking, describing the who, the what, the where. Analytic studies is looking at more of like the why. With a case control study, we've got two groups of people. You're looking at one group with the condition that you're interested in and one group that is very similar to them in every other way, but they don't have the condition that's interesting to you. So looking at what's different about them. So if we look at case control studies, we do them for foodborne outbreaks all the time. If 100 people went to a wedding and 50 got sick and 50 didn't get sick, or 50 are the cases and the other 50 are the controls, what's different about them gives us some clue as to why the people who got the disease may have gotten it as opposed to the people who didn't. That's just an example. A cohort study, it's a longitudinal study, so it goes over many years. You can do these prospectively or retrospectively, but we're looking at a certain group of people and studying them over a group of time to look at health outcomes and making determinations then as to why they might have had certain health outcomes. You can also look backwards. So we could take a group now. They've done a longitudinal study. I think I know they're still doing it of first responders who were at World Trade Center on 9/11. They're doing a longitudinal study of their health, of the survivors from that, because there were so many environmental factors, obviously stress factors. So they're doing a longitudinal study of this cohort and looking at health outcomes. You can also take a group now, and it's hard because you have to have them participate, right? They have to agree. You've got to, have them, answer questionnaires, take part in all of your testing that you want to do. So you have to have, buy-in, obviously. If you want to go backwards, we could take like a group of, you could take a group of people who have any particular interest to you now, maybe people who are 30 years old who have a certain type of breast cancer, and do a retrospective and look at their medical records for their whole life to see what led up to this current state now, to draw conclusions as to what might have contributed to a certain disease state. Does anyone take part in the Nurses Health Study? Okay, so if you want to be a part of research and science, it's a really easy way to do it. It's been going on for a really long time. It's called, just Google Nurses Health Study. We're on like the third phase, and it's open to nursing students and any nurses. And why nurses? I think because we're really good at answering questionnaires and like really being on top of it, and like we're a pretty reliable group to study. But that's sort of a cohort study. Like they're looking at basically taking groups and looking at your whole life health history. So I answer questionnaires quarterly on my reproductive history, my dietary history, my exercise history, my disease history, et cetera. Just now I did some lab samples for them, but it's pretty interesting. So and they just take that information and they use their, biostatistics to calculate, risk and odds of certain people who've had certain health practices ending up with a certain health condition, right? So you might read a study that says, oh, people who eat blueberries are more likely to not get certain types of cancer. That's where they're drawing those kind of conclusions. And there's many levels of quality of that kind of data. A couple things that they determine from descriptive studies are relative risk and odds ratio, which is basically just looking at determining statistically and putting a number, a percentage on it, who is more likely to get certain diseases or have certain health conditions versus others. Right. Okay, so I got through biostats really fast, and now you're ready to like calculate some p-scores and t-scores and flashbacks. I would like to say there are professionals for that. There are biostatisticians for that. Okay, so we are now talking about infectious versus chronic disease. Okay. Things we're looking at for infectious diseases, obviously it's an infectious agent. So we're looking specifically at a bacteria, a virus, a fungus, a parasite, that they can multiply and cause disease in hosts. Okay, so for a disease, so we're looking at communicable versus infectious. So for something to be communicable, that's another word for contagious, right? There must be a portal of exit from the person who's infected So say I've got RSV, to, or person or animal, and a means of transmission and a portal of entry. So what's the means of transmission? If I have RSV, it's probably airborne, maybe droplet. And then there has to be a portal of entry to the person that's going to get it. So you breathe it in through the lungs, right? For Mpox, it would exit through a lesion. It's transmitted through skin-to-skin contact, and the portal of entry would be mucosal membrane or a opening in the skin of the person. So any disease you can think, we're going back to whether it's, you know, airborne and whether the other person can get it. Rabies is interesting because we just had this rabies dog yesterday. Rabies is transmissible. It's in the saliva. And so it's really transmissible through like a bite or a scratch, and really a scratch because if the animal's been licking its paws and then scratches you, it could, like right away, it could give it to you potentially. So we're looking at, we had this dog that came up to be rabid, means of transmission. It was drooling all over the place. It wasn't aggressive, so it wasn't biting people. But that's like, it was portal of exit was through all this. They can't manage their secretions through drool. The means of transmission, the person was taking care of this dog and, you know, had it in the car, and the dog was very friendly at first, licking and things like that. So the means of transmission there, even though it didn't bite her, could have been like an open sore on the skin, letting some of the dog's saliva into it, a scratch or something like that. And that's your, you know, portal of entry. Well, just a good example. I always like to talk about the latest thing that we're working on in the system. We were working on the press release all morning. Okay, talked about that. Incubation period, you know what the incubation period is basically the time between when you get infected to when you become contagious or experience symptoms. So like the common cold has a really short incubation period, like a rhinovirus might be like 2 days, whereas a COVID can be as long as, we used to think up to 2 weeks. It can be up to 2 weeks, more like 5 to 7 days. And again, we know incubation periods from knowing the natural history of disease, from being able to study that. Okay, so other things we're looking at, we talked about the environment, we talked about different types of transmission. You've got airborne, where it's kind of aerosolized. Droplet is where it's got to like actually be in a droplet of saliva and like go out and hit you. And that's more like TB. Ingestion, you might eat something like a food poisoning or drink water that's got some spores in it. Sexual transmission, skin to skin, which is really close, which is like your Mpox, your HPV, herpes, and then blood transmission, body fluids. And of course, there's other ones, but those are the main ones that we're looking at. Okay, does anyone know typhoid Mary? You're in public health. Okay. Really interesting documentary. If you want to look it up, I'm sure you can find it on YouTube. So typhoid is actually, it's a form of salmonella. And so the reason why they're using typhoid Mary is there's this woman named Mary, clearly. And she was a carrier of typhoid, which means she carried that infection. And she harbored that infectious organism, but she never had any symptoms. Yet she spread it to a lot of people. So she was a carrier, and it's a really kind of a sad story. It ended up they ended up putting her like on a remote island, stop spreading it, and that would never happen nowadays. But Google typhoid Mary, there's a really good documentary. But she was a carrier, like she carried typhoid. It just never cleared it. Her body didn't clear it, but it didn't make her sick. But she was taking care of families and cooking for them and stuff. And this is a long time ago, so this was before probably great sanitation and great indoor plumbing and stuff. So maybe not the best hand washing practices. And infecting all of these families and children with typhoid. So, you know, epidemiological investigation tracked her down, but really interesting. Okay, so colonization is when you've got the organism and it's multiplying in your body, it's colonizing you. Some people can be colonized and not be infectious. Like we'll see, like 10% of the population is colonized with Neisseria meningitidis, which is the bacteria that causes the bad bacterial meningitis. So they're colonized, and if you do like a nasal or throat swab, you might find it might grow, but they have no symptoms, they're not infectious. We don't really do anything for them, we just know they're colonized with it. It is just like part of their normal flora. So that's colonization. Doesn't necessarily mean they're infectious. Oh, here we go. Oh, look at that. Okay. So then some more of my fancy animation. Okay, and then the incubation period, we talked about that. So from the initial contact to when the person first gets sick. Okay, question. Is the following statement true or false? An infectious disease is always contagious or communicable? False. An infectious disease may not be. So for example, malaria is infectious, but it's not contagious. So if I have malaria, I can't pass it on to you. Measles, it's both infectious and contagious. Now, tuberculosis is always infectious. It's an infection. It's not always contagious. So pulmonary is generally contagious, but TB can go anywhere in your body. So if I have TB of like the knee joint, I can't pass my TB on to you. I mean, technically I could if you were like doing surgery in there, but generally not. We get TB cases, lots of eyes, it's one of the leading causes of infertility in certain developing countries because of uterine TB. Very interesting. I have the TB program under me. It's a fascinating disease. Okay. Talked about outbreak investigations. This is what we're looking at. This is what our nurses are doing. Who got sick? Where were they? What were they doing? They're asking them all the questions. Like they will be like, pull out your calendar and what were you doing on October 3rd? Where did you eat? What did you do? And people will be like, I don't know. I usually eat a peanut butter sandwich. It's really hard to remember what you ate a month ago when you get food poisoning. So if you ever do think you get food poisoning, like write down everything you eat for the past 3 days right away. It helps the investigation. Okay, healthcare associated infections. This is really important, and you'll hopefully learn a lot of really good infection control practices in the hospital, or if you work in a long-term care, it's becoming more and more important because we're having more and more pathogens and infections that are becoming more common in healthcare settings and more resistant. So getting a lot of resistant microorganisms, MDROs, multi-drug resistant organisms. I'm on like a state task force about this. So hand washing, using alcohol-based hand sanitizer, highly encourage you to just like be very vigilant about that. Okay, these are all the different kinds of diseases. I think I've talked about it: foodborne, waterborne, vector, respiratory, vaccine, and sexually I didn't talk about sexually transmitted a lot. We don't do a ton of that. We have a different unit that deals with that. They actually do testing and stuff like that. We do the data on it. These are all really great resources. If you have any interest, they're all, I think, clickable links. If you have any interest in continued reading about epidemiology or communicable diseases, I included the public health code because we get this question all the time. We'll call healthcare providers who might be a little bit newer, and they're like, I can't tell you HIPAA, I can't tell you it's HIPAA. Well, HIPAA only, it's a very specific law and it only applies in certain instances, but healthcare providers, schools, labs are actually required to tell us we don't fall under that HIPAA law. They're required to give us communicable disease information. They only have to give us what we need to know. They don't need to tell us like way more than we need to know, but they are required to tell us that. So every so often we'll have to pull out the public health code and fax it over to the provider and say, it's, you know, the public health code, this doesn't fall under the law of HIPAA. You're allowed to, you must give us this information. A lot of that we haven't ran into during COVID, a lot, especially with the schools. All right, and this is like almost like my quote from early days of COVID. The way we work in public health is we make the best recommendations and decisions based on the best available data. So like early COVID days, we knew nothing. Our phones were ringing off the hook. We had providers, we had schools, we had public calling us. We couldn't even keep up. We had a whole wall full of sticky notes, and we would categorize them: healthcare providers, schools, general public, and then you just like go by, grab a sticky note, return phone calls. But information was changing so quickly, like really, like we'd say one thing in the morning and it would change by the end of the day. And so my motto was, and I had it written on the wall, was we're doing the best we can with the information we have available at the time and the resources that we have available right now. And that's really what we do in public health and in healthcare, I think, generally, is you have to make the best recommendations, give the best care you can based on the knowledge that you have and the resources that you have available. And that's it. Yeah. Anyone have any questions? If you guys have time later, you can always do that activity where it's kind of fun to do, where you just take the ecological model, and I laid out some blank slides where you think of a particular patient and what their diagnosis is, and just break it down. Like, what are the intrapersonal factors that are going to affect this patient's health, and what are the interventions I can do as a nurse, and what are the interpersonal factors, the institutional community, and just consider all of that. It just makes you kind of step back and consider like the bigger picture of your patient rather than like, I got to put a Foley catheter in. So, and if you ever, we do hire new grads. at the health department, but I understand a lot of people are gonna go out for elsewhere, but I'll leave a couple cards if you even are interested, and like, we are happy to have people shadow. I'm clearly pretty passionate about public health. I'm happy to talk about it. Anytime, so I'll leave some cards if you guys want to reach out. Does anyone have any? No. Thank you for your attention, you guys, and congratulations. I'm excited for you.
Thank you.
Thank you.
All right. Done. So, Teresa and I were neighbors. Like,
Yeah, I know. That's great. Great time.